Well, welcome, bright and shiny this morning, so it's great to see you. On behalf of Designs for Vision and Oculus, I'd like to say thank you for joining us. It's wonderful to be back at Bransco, and we appreciate you joining us this morning. We are fortunate to have three very experienced clinicians and active researchers to share their experience regarding the Pentacam family and Corvus. Professor Michael Bellin, Dr. Brendan Cronin, and Dr. John Malesh. But before I welcome them to speak, I wanted to touch on the anniversary of the Pentacam family. So Oculus has a rich history that spans over 100 years. With the launch of Pentacam 20 years ago, Oculus was pioneered and launched into Australia by Mr. Richard Grills. We take this opportunity to remember him after his sad passing in July. The founder of our company and the leader of our tribe, he was truly an inspirational human who was passionate about advancing ophthalmology through innovation, challenging the status quo and working together to find solutions that improve eye care. And since that time, 20 years ago, the Pentacam continues to be reinvented with new, more meaningful ways to help clinical practice. We've had 28 software versions and now onto the fourth device with the AXL Wave, each time bringing new and meaningful data and reports for pre- and post-operative needs. So bringing that to life, firstly I welcome Dr. John Malesh to share his experience using the Pentacam family, the entire family, because he has the full suite across all of the Pentacam family, for early detection, decision-making across cataract, laser refractive and corneal surgery. So please welcome Dr. Malesh. He's the principal surgeon at Envision Eye Centre in Sydney, a corneal refractive and anterior segment surgeon. He sees a diverse cohort of patients in Sydney. Dr. Malesh is passionate about innovating and constantly improving his clinical practice and is an early adopter pioneering SMILE refractive surgery in Australia. So please welcome Dr. Malesh.
Thank you very much, and thank you for coming this early. One thing I'll say about Pentacam is that they've been very good at supporting their product. I still have my original Pentacam, which I think I bought 15 years ago, and it still sits in the practice and still works, and it's still supported, which is nice in these days when sometimes these devices don't get supported for too long. Anyway, I think that today I wanted to talk about just a sort of a grab bag of different ways that we use the Pentacam in our practice, and because it has a lot of different imaging modalities, we find that we use the Pentacam for a lot of different things. So the first thing I'll talk about a little bit is IOL selection planning. So we have a number of IOLs that we can use now. We have monofocal and multifocal IOLs, we have aspheric, neutral, spherical IOLs, and we have patients who are asking us what lens can they have, and we need to make decisions about can a patient have a particular type of lens style. And clearly this is not just purely a choice with regards to corneal parameters, but it is something to consider. So in addition to all the other things that we consider, lifestyle, personality, and the other factors that we need to consider when we're deciding whether a patient is suitable for a trifocal intraocular lens, for example, we need to see whether their eye will actually be suitable for that. And the Pentacam cataract assessment page, which you see here, has a lot of information which looks at corneal regularity, the tomography data, and a few important things with regards to aberrations, which I think we need to consider with multifocal lenses in particular. So with this cornea, which was spectacularly normal, being mine, had higher order aberrations of 0.143 and spherical aberrations of 0.273 microns. And there are some cutoffs, and you can argue about what they should be, but if you have corneas that have relatively higher order aberrations or high spherical aberration, then you start to wonder whether they're going to be more likely to have issues with multifocal lens implantation, and something that you need to discuss and decide whether that may not be an appropriate choice for a particular patient. And then, there may be a slightly less a strict cutoff for an extended depth of focus lens, and then maybe think about other options such as monovision if they have more aberrated corneas. And so if you look at an eye that's perhaps had LASIK before, this is an eye that had LASIK but has a reasonably regular cornea. The higher order aberrations are still relatively low, and the spherical aberrations are also pretty low. So you think that perhaps maybe one of those types of lens options would be a reasonable one to consider. And then you can go to the other extreme, someone who's had previous radial keratotomies, has very higher order aberrations and very high spherical aberration, and clearly, multifocal style intraocular lenses would not be a good choice in this particular circumstance, given that their cornea is already very multifocal. Now, the EKR report is also a very good way to get an idea about how regular a cornea is, and it will give you, within a zone, how much variation there is in the keratometry values. And if you see a nice sort of tight spread between the keratometry values in a cornea, that means that the cornea in the zone that you've picked, and by default it's at 4.5 millimeters, has a fairly small range of keratometry values. If you have, this is a post-LASIK cornea that has a slightly wider spread of, or somewhat wider spread of keratometry values in that area. And then if you look at that RK cornea we saw before, the range of keratometry values in the first 4.5 millimeters is very wide, and therefore there's a lot of irregularity there. And in this sort of case, you may be thinking about some sort of pinhole style lens like the IC8 to try and reduce aberrations rather than any sort of multifocal style lens. So in terms of IOL planning, I find the Pentacam is very useful to figure out corneal parameters that might dissuade you from using one of the multifocal style lenses. And you can also use it to figure out whether you think a neutrally aspheric lens or a negatively aspheric lens may be a better option, depending on the asphericity of a particular cornea. I'm sure Professor Bellin will go through this in much more detail, but in terms of ectasia progression, looking at keratoconus, I think that there's no better tool than the Pentacam, just because it just manages the data so well with the help of Professor Bellin's software. So this is a patient who has keratoconus, first saw at the age of 17, had progressive keratoconus, right eye's been pretty good, and over the years we were flicking through different scans looking to see, is it getting worse, is it not? And then the magic of the ABCD Bellin progression scan, progression data came along and made it very much easier to manage. And this is just a little snippet of it, but basically this snippet shows the anterior and posterior corneal curvatures in the left eye, and the bar graph going to the right is getting worse, and the going down here is the progression over time. And so over the first time that I saw him, the first few visits in 2013, you could see that the keratometry was worsening. We decided to go ahead and do cross-linking at this point, and you can see that over time, the progression of the anterior radius of curvature was downwards. Now, interestingly, the posterior radius has been reasonably stable, but perhaps has jumped up a little bit, so we're keeping a watch on that. But there is a little bit of fluctuation from measurement to measurement, so at the moment we're pretty happy that his vision is stable. So you can see all this data by just looking at the individual scans, but in terms of a quick summary of a patient who's been coming for years, it's just so much easier to look at this and make an informed decision about how they're going. And then you can look at the other eye that hasn't been cross-linked to see if there's been any progression, which there hasn't in this case. So it just makes life much easier in terms of time management and making sure you don't miss a small change, and at the same time kind of ignoring the small random fluctuations that you get from one visit to the next by looking at the trends over time. Sometimes you get these really funny corneas. I certainly do. This was a lady who had herpetic scarring of the right cornea, and she had poor vision in this eye. It was hand movements vision with a brunescent cataract, but she said that her vision was much worse than it usually was, and it was affecting her navigation and so forth. And when you looked at her cornea on the Scheimpflug image that you also get on the Pentacam, there's a lot of white here, so there's a lot of opacification, and if you look at the anterior tomography, there was a lot of irregularity as well. And when we tried to do biometry with the IOL master, the keratometry just wasn't possible because there was just too much irregularity in that right eye, whereas with the normal left eye you can see the nice clear spots. So In terms of figuring out the keratometry values for the right eye with the cataract surgery, we've got a couple of options. You can use an alternative. You can use the measurements from the other eye, or you can also use the Pentacam, which was our choice in this circumstance, to get some sort of average keratometry value. Now, we're not looking for a 6/5 outcome here, but we're looking to get some sort of reasonable improvement in vision. Because the Pentacam doesn't rely on an optical measure of the keratometry values, rather it's elevation data, it can give you a SIMK even in quite aberrated corneas. So we went ahead and calculated a lens for the right eye based on those Pentacam keratometry values. As it turned out, if we used the optical measurements from the other eye and plugged that in, it actually gave the same answer. But I was more inclined to believe the Pentacam on the right eye in this circumstance. And in this case, she went to 636 following her surgery, which she said was her normal vision. So that's a nice way to look at these, image these aberrated corneas. Another one is seeing patients who have sort of funny corneas to see whether, or to explain to them why they can't see. This was a patient who had a intraoperative issue during smile surgery, had very prolonged lenticule dissection in both eyes, and had quite poor vision 5 months after his surgery. And you can see his refraction there. His vision, best corrected vision, was still pretty poor at this point. And when you look at the Scheimpflug image here, you can see there's a lot of haze or scarring within the interface, which is likely contributing to that. And also, if you look at the tomography data, particularly in the right eye, it was very irregular. And we're still trying to sort out exactly what happened during the surgery. I suspect there may be some retained lenticule fragments, but there's a lot of irregularity there. Now, the Pentacam aberrometry data can give you some idea about how irregular that cornea is, and gives you the measurements which show that there is a lot of irregularity. And one thing that was quite useful to the patient was looking at the visual performance scan, which is available on the new Pentacam, and saying that this is based on your cornea, what you should be able to see. And you can see that E is very aberrated, and that sort of gave me an idea of what's going on there. And so we're still sorting out what to do with this gentleman. It may well be just, unfortunately, rigid gas permeable contact lenses, or we may be able to do a laser phototherapeutic keratectomy. But it was helpful to the patient in particular to sort of explain why it is that he is having trouble seeing with that imaging. And the other eye is similar, but not quite as bad, and faces similar issues. So because we have this ability to image the cornea, we can look at the corneal irregularity, we can look at corneal caves and scarring. Because we can look at the corneal cataract density as well, we can document cataract density both for ourselves and for make sure that people know that we are actually performing cataract surgery on cataracts. And the last case, just IOL position. This is something that we need to consider for toric IOLs, and this was a gentleman who had cataract surgery and was very good at week 1 with 6/5 unaided vision in both eyes, had a 3 diopter of toricity in his intraocular lens, and at 1 month his vision had dropped to 6/9 on the right eye. And on the retro illumination picture, we could see that his lens was at an axis of 159 degrees. I think I've kind of obscured the toric markings, but they're underneath that line that you put up. And originally the lens was at 178 degrees. You can then plug the numbers into one of the calculators to figure out what change in position will do to the refraction. We knew that the refraction should be good with the original position because it was at the start, and it was confirmed with this saying if you rotate the lens 17 degrees anti-clockwise, it should correct most of the refractive error, and it did. So it's a very useful tool to document and to calculate this sort of issue. And one last thing, Pentacam is a great autorefractor in the AXL. You can use it to refract based on pupil size as well, and the aberrometry-based autorefractors are great, particularly looking at toric IOL refractions as well, which are sometimes harder to check with conventional style autorefractors. And that's basically my sort of grab bag of different things that I use the Pentacam for. It's got a lot of different imaging modalities, and I find it's a very useful tool in our practice. Thank you very much.
Actually, we will do question time at the end if that's okay, just to make sure we're running to time. So I'd like to welcome Dr. Cronin, the Director of Education at the Queensland Eye Institute, and of course a well-known local. And beg your pardon, it's Iggy, where have I? I've just lost. Well, Dr. Cronin doesn't even need any introduction, really. So, a corneal specialist with a special interest in the Athens Protocol for corneal resurfacing. Dr. Cronin uses the biomechanics data from the Oculus Corvus as well, combined with the Pentacam, so which is something that's going to be available here as well to have a look at if anyone would like to have a look at that. So, I would like to welcome Dr. Cronin to the stage.
Okay, welcome everyone. Thank you so much for coming. So I'm going to cover some of the features of the Oculus Corvus and how it can be used in your practice, and not just from a cornea perspective, but also a glaucoma perspective. So think about how you check the pressure in a car tyre when you go to the service station, and I'm sure we're all meant to do it every couple of months, but you actually put the pressure sensor onto the little valve on the tyre and you physically measure the pressure inside the tyre. And that's because a car has a valve, but the cornea doesn't, unfortunately. So the equivalent is that we have to stick a little probe into the eye and actually measure the pressure in the aqueous in the eye, which isn't so easy to do. So what we're effectively doing when we measure the pressure in anyone's eye is we're kicking the car tyre. And we're kicking it with very sensitive machines, and they're planting onto the cornea. They use different formulas to work out what the pressure is in the eye. But we're assuming that every eye or every tyre is the same. And if you're doing it in a tyre, you'd have different variables like tyre thickness, steel wheel radials, retreads, low profile tyres, big thick truck tyres, and the biomechanics of each one of those tyres is different. But all of the traditional IOP measurements don't factor in is the thickness of the cornea, the structural rigidity of the cornea, or the biomechanics of the cornea. So it's time to move on from checking the eye pressure just by essentially kicking the tyre. So all corneas are all different, and that's the important thing here. So the benefits of the Corvus are that in glaucoma we can measure more accurate pressure, a biomechanical IOP. It's fantastic at diagnosing normal tension glaucoma, and I'll show you some cases of that, and risk stratification in glaucoma. And then of course in cornea we can use it for safety and refractive surgery, diagnosing ectasias, and also I'll show you how you can use it to do customised treatments for some different ectasias. So that's the machine there, the Oculus Corvus, and I'm sure there'll be one in the trade hall. I'm not going to go through the biomechanics because they're complex and pretty boring and I don't understand all of them. But I do like the graph. So just a few cases here. So this was an ophthalmologist's formal partner. And she was 32 years old, and she'd been treated for quite a few years for high intraocular pressures, just ocular hypertension. She didn't have any nerve damage. And she was on Lumigan and Combigan and had sort of, as she described, ugly eyes. Now, she and her former partner had since broken up and married separately, but I kind of always laughed that, maybe he was just trying to get a bit of revenge on her. But anyway, they were her pressures on eye care and Goldman, and we'd done Pascal tonometry as well. But Lumigan and Combigan didn't make a huge difference to the IOP, but her biomechanical IOPs were all completely normal. And I've been seeing it for a couple of years now. As you can see there, maximum IOP or biomechanically adjusted IOP is 24, and she's got a pretty normal thickness cornea. And so I've just watched her for 2 years. She's off all of her drops, her nerve hasn't changed, and her pressures really haven't fluctuated much at all off medication. So that's an example of where the biomechanical IOP, factoring in what brand and what type of car tyre you've got, can really advantage your patients. And you'll see these young people, I find this really commonly in those young people with quite high pressures, that their biomechanical IOP is perfectly normal. And people are talking about trabeculectomies, but they probably don't need anything. So as I say, she's been off drops for a couple of years, and the pressures are perfectly normal now. You see that quite a bit. The other one is normal tension glaucoma. So normal tension glaucoma is a pain in the backside. You get centred in, is this normal tension glaucoma? And we normally all over investigate, and we do 24-hour blood pressures, and they score an MRI, and you watch them heaps, and they get fields done. In the end, after 3 or 4 years, they say, so do I have glaucoma? And you go, maybe not. It's hard to say. Keep coming back every year, or just go to your optometrist. Well, just do something. And it's hard. It's hard to diagnose them. So the Corvus can assist with that with just one quick test in your clinic. Basically, the Corvus can diagnose normal tension glaucoma with about 75% sensitivity and 75% specificity just on one quick air puff test. And so it looks at the biomechanics, and the database has stratified patients with normal tension glaucoma, and it gives you a screen like this. This is the same as the screen for the other patient. But this was just a normal patient I had in clinic. There was this query normal tension glaucoma, and I thought, I really couldn't be bothered. I didn't love the patient. I didn't really want to see him 7 or 8 times over the next 5 years. I won't lie. But he was grumpy. He didn't really want to be there. He didn't understand. He didn't have any visual problem. But as you can see here, it's put him at the extreme end of the range for normal tension glaucoma. Now, his nerve was still pretty healthy, but the optometrist documented there was a bit of a change. And so pretty much straight up from there, I could say, yes, you do have normal tension glaucoma. And the best part for me is I could send it to a glaucoma specialist. I didn't have to look after it. But in terms of diagnosing normal tension glaucoma, you don't tend to get too many in the middle here where you're uncertain. You either tend to be told, look, they're in the normal population, or they're very much in the normal tension glaucoma population. So it's a fantastic tool for that. And the other one is a risk stratification of corneal parameters. So this one's great because it's mostly a bunch of Aussies, sort of led by Jamie Craig in Adelaide. And basically they're looking at corneal stiffness parameters for those glaucoma suspects to see if they'll progress. And so how's it useful? So basically you've got to think of corneal biomechanics, and what are they? What do they mean? So corneal hysteresis is sort of the dampening or the viscoelastic effect of the cornea. So lower hysteresis is bad in that it has less shock absorption capability. So higher hysteresis being better. And so people talk or postulate about what the mechanisms of all of this is, but you don't have to be too smart. You can just remember that a thick floppy cornea is better than a thin stiff one. And so if the patient's cornea is less than 550 microns, and then one of their parameters that I know looks scary, the milliliters of mercury per millimetre, but on the printouts or on the screens in the Corvus, it's very obvious. So if they've got a high, a thin, stiff cornea, then they're much more likely to progress than those glaucoma suspects who aren't, or even just general glaucoma patients. So it really does help you risk stratify your glaucoma patients. We all know those sort of risk factors for glaucoma progression based on the ocular hypertension treatment study, but now at the bottom you can really add corneal stiffness parameters. It really does determine how often you have to watch your glaucoma patients. But let's face it, cornea is sexier than glaucoma, so we'll move on from that. I think so anyway. So ectasia detection and management, basically we try and determine the strength of corneas by looking at their shape, and that's fantastic. And people have done great work on that to look at the shape and work out the biomechanics based, or work out the structural integrity of the cornea based on topography and tomography. But we can move on from that. So these are the old screens we're used to in biomechanics, and that's just a standard Pentacam printout. But this is the new integrated report that you get when you've got the Corvus and the Pentacam working together. And so it gives you the corneal biomechanics as well as the corneal topography and tomography. And you can it integrates them for you and spits out some really easy parameters so that you can safely use these in assisting to diagnose ectasias, LASIK screening or refractive surgery screening to ensure you're ruling out those patients who are likely to get ectasia. And also importantly, it doesn't often need to rule patients out, but often it will rule patients in where their cornea is a tiny bit thin and you say, well, it's perfectly structurally fine. You might have cross-linked a keratoconic patient, but they've got a little bit of lousy vision and they want a PTK to smooth out some of the irregularity. And you can look at it and say, look, your cornea is pretty stiff. You don't need cross-linking at the same time. So you can do biomechanical maps. This is sort of secondary software, but we plug our biomechanics from the Corvus into some software and it prints out a biomechanical map like that one over on the left there. And you can see the biomechanics of the cornea don't necessarily match up with where the cornea is weakest or steepest. They match up with where it's weakest, but it doesn't match up with where it's steepest. And then we plug that into our crosslinker, which is a topography guided cross-linking machine, and do a customized algorithm for their cross-linking. And you're cross-linking the weaker parts of their cornea instead of just the steepest parts of their cornea. And you get some pretty awesome results. You can see that patient there. So they're pre-topography and post-topography in their difference map. You pretty much can't tell that patient has keratoconus anymore. So by treating the weaker parts of their cornea, you can get significantly improved corneal topography post-collagen cross-linking. And we've sort of published that we've shown increased rigidity after corneal cross-linking 6 months after the procedure. You can show your keratoconic patients really like seeing that my cornea is much stiffer, it's much stronger, and they're sort of reassured by that, and just showing some pretty unexciting maps there of the increase in biomechanics in a cornea post-cross-linking. You'll sometimes get the Corvus rule out patients for you. So this is a patient with pretty normal topography, 512 micron cornea. They'd been booked for LASIK a couple of years prior by someone else, thankfully, but hadn't had it done just due to finances. But the Corvus has pretty much ruled them out as a LASIK candidate. So it is really nice to have that extra little safety margin with the Corvus to tell you who are your good LASIK patients. And again, you can plug it into some external software, and it will tell you if a patient is a good candidate for a refractive surgery. It plugs it through an algorithm. You plug in what their refraction is, what procedure you're going to do, the diameter of your flap, and it will tell you if they'll have adequate structural integrity in their eye post LASIK. So it's really nice for those cases that may be a little bit borderline, where for some reason they don't want a PRK. And it can sometimes rule them in or out for a PRK as well. And then further integration of that, as you're about to learn with the ABCDE screens, just makes life really easy. The software integrates the two machines really well for you. It's very, very easy. You don't have to understand how it works or really understand complex graphs. It puts things into a nice, simple display. So you really don't have to have a PhD in biomechanics to understand it. But certainly there's a lot of uses for it in your clinic on a day-to-day basis. Excellent. Thank you.
So we now welcome Professor Michael Ballin. Excellent. So from Tucson, Arizona, he is certainly no stranger to Australia and to RANZCO. He holds a number of leadership positions in Arizona, New York, Ontario. He's been instrumental in the development of key Pentacam parameters, applications, analysis displays, reports, of course, including advanced keratoconus, ectasia screening, and the latest ABCD keratoconus progression displays, which we've just seen. So we now look forward to his extensive insights that he's going to be sharing. Thanks.
Thank you very much. This is, I think, my 15th or 16th trip to Australia, and maybe my 14th RANZCO meeting. And I think in a year or two I'll actually learn the language. So what I'm really going to talk about is the ABCD staging and progression, but we always kind of start off with a quick background. I'm curious for the audience, how many of you have Pentacams? Okay, so about 2/3. So most of you are familiar with the BAD display or the Bellin-Ambrosia display. It actually is divided into kind of two different sections. The left section, and my pointer's not working well, there it is elevation based, and the right section over here is pachymetric based. And what these maps are, this is a standard elevation map using a 8mm best fit sphere as a reference surface. The second one uses something we called an enhanced reference surface, and I'm going to show you what that is later. And again, these are Renato's graphs here, which are pachymetric progression graphs. You understand the BAD display was designed really for refractive screening. It separates normal from abnormal. The final D in itself doesn't specifically diagnose keratoconus. And a lot of people have misconceptions. You read some articles where they go, well, we're comparing this versus another software. The final D shows you deviation from normal, not necessarily keratoconus. I had mentioned that enhanced reference surface. Now, normally when we look at elevation, we use an 8mm reference surface, and we take all the information out of that 8mm. The enhanced reference surface effectively excludes the area surrounding the cone. Now, when we teach it, we kind of say it's a 3mm zone, It's actually a dynamic number that has a very difficult algorithm that actually it varies between a 3 and 4mm exclusion zone. So we actually exclude this area from the computation of the best fit sphere. We call it again an enhanced reference surface. That's done because it accentuates the cone. Now, the other part of the Bellin-Ambroge display is the pachymetric progression. And why is that more valid to look at than just a simple pachymetric reading? So there's just two examples. One I'm going to show you is on the top. These are two corneas that have the exact same central apical reading. So if what you took was an apical reading, these two would look the same. But if you look at the pachymetric progression on the left, it's pretty much right down the middle. It's a normal pachymetric progression. It's a thin but otherwise normal cornea. If you look at the right, you can see here on the pachymetric progression, it's well outside the normal range. Again, an abnormal cornea, keratoconic cornea, will have a more rapid change from the more normal periphery to the thinnest point. So these are two, again, corneas which would have identical central apical readings. One is a normal thin cornea, the other one is highly suggestive of ectasia. The reason I start off with that background, because it'll kind of introduce the ABCD. So we looked at the bad display and we said, this works because when we remove that, quote, 3 to 4 millimeter zone, we remove the bulk of the cone. Well, if that works, then why don't we just look at that it actually turns out if you have a keratocone, it's almost always a 3 millimeter zone. That if that works to exclude it, why don't we just look at that, because that best describes the cone. So we say here the enhanced reference surface works because the exclusion zone effectively removes the bulk of that ectatic region. But as opposed to removing it, if you want to look at the cone, you want to describe the cone, we should examine that exclusion zone. So on the ABCD, which is what you see here, it's not important what the numbers are, the machine does it for you. The A and the B are a 3 millimeter optical zone centered on the thinnest point. So it's basically the opposite of what we do for the bad display. So the A parameter, A is for anterior, is the anterior radius of curvature from a 3 millimeter optical zone centered on the thinnest point. B stands for back as opposed to posterior. Why? Because APC doesn't sound nearly as classy. So B stands for the back of the cornea. Again, it's a 3 millimeter optical zone centered on the thinnest point. C is the actual thinnest point of the cornea. And D is not machine generated, it's user generated, and it's the best spectacle corrected visual acuity. As you heard earlier, there will be soon a release of an additional parameter based on the Corvus, which will be an E parameter, which will be added on to both the progression display and the classification. And it's currently, the ABCD classification is currently seen on the what's called the topometric keratoconus staging. I'll show you just a little blow up of it here. Actually, I'm going to back up. So it actually gives you 3 bits of information. It gives you the actual staging, which is the least informative. And that's here you can see we have A0, B4, C3, D0. What does that mean? It means you have fairly advanced keratoconus with a normal anterior surface. You have a big posterior ectasia in spite of a normal anterior surface. With the normal anterior surface, distance visual acuity is still good. The cornea is mildly thinned at C3. Least informative. This is a graphical analysis, and you can see here that the A surface is very normal. You can see here it's a little bit past the 3, but the most useful information specific for the patient is actually the actual numbers here, showing what the radius of curvature is on the anterior surface, posterior surface, what the thinnest cornea is, and what the distance visual acuity. Why radius of curvature? Because when you're dealing with the back of the cornea, diopters are not very intuitive. If I was to tell you, the back of the cornea is a low power minus lens. If I was to tell you, well, your posterior curvature is -7 diopters, intuitively you can't really think about it. So radius of curvature allows the front and the back to be compared. So why do we have a progression display then? We have the bad display, we have the ABCD classification. So we always get this question, can't we just follow the final D from the bad display? Or can't we just follow the parameters from the ABCD progression display? Well, as I said earlier, the bad display is designed specifically to separate normal from abnormal. If you look at the picture on your lower left, it's definitely a very abnormal eye. it's post-refractive, and it should be abnormal. If you look at the one on the lower right, this is an eye with endothelial dysfunction, corneal edema, again, not normal, and the final D should be abnormal. The upper right here is hyperopic LASIK. The anterior surface looks very much like keratoconus. Obviously, you don't have posterior change, but again, it's not a normal cornea. So again, the bad display is designed to separate normal from abnormal. I mentioned not specific in itself, without some additional parameters for keratoconus. Well, how about the ABCD classification? Well, gradings or classifications are really designed more for population-based studies. What do we mean by that? Well, if you look here at body mass index, if you look here, if someone started off at 18.5 and went to 24.9, this is a huge change. They still would be in the same stage. Meanwhile, if someone went from 24.9 to 25, they would jump to a whole different grade. So gradings are really good for population. They're not really good for following individual patients. And if we look at the 2015 Global Consensus article, I bring it up just because they make a point here. The following findings are mandatory to diagnose keratoconus. If underlined, the first thing they notice is an abnormal posterior elevation. Why am I mentioning that? Because if you look at all the prior progression determinants from the literature, if you look down this long list, except for pachymetry, every single one of these is anterior curvature based, anterior surface based. And again, if you go back to that 2015 classic Global Consensus article, which was from the 4 major cornea societies, Cornea Society, Eucornea, Asia Cornea, and Pan Cornea, the first thing they mentioned about diagnosing keratoconus is an abnormal posterior surface. But again, if you look at all past progression parameters other than pachymetry, they were all anterior surface based. Additionally, none of them have actually been validated. Even that one diopter change in Kmax, other than the fact that Glaukos or Vidro used it, it's never been a validated parameter. So why do we need a new progression display? Well, it was designed to allow us to follow and document progression of disease. It's based on one-sided confidence intervals. Why one-sided? Because we're only interested if the cornea steepens or thins. It allows documenting progression. I'll show you some clinical examples in spite of a stable anterior surface. So if we go back to all those prior parameters, they were all anterior surface. It allows us to document progression in spite of a stable Kmax, and evaluates each anatomical layer, anterior surface, posterior surface, and corneal thickness individually, and it has been statistically validated. When we did this originally, we decided it was very important to determine those confidence intervals from 2 different populations. One is a normal population, and the other one is keratoconic or an abnormal. The reason for that is for your older, more established, advanced keratoconic patients. Using noise levels from a keratoconic population are more appropriate. All of us know no matter what measurement you're taking, what machine you're using, the more abnormal the cornea, the more noisy the measurement. So again, for your older, more established patients, we have a keratoconic-based database. But for your young, very early subclinical cones, the noise levels on those probably more mimic the normal population. In addition, it's probably of greater risk waiting and watching a very young patient. So we again have 2 databases. You can choose clinically which to use, but in general, the normal population is what we use for the very early disease, and the keratoconic for the older, more established disease. And this was the second iteration of the progression display. It defaults to show you both the normal gates or normal confidence intervals in green and the keratoconic in red. We show you 2 confidence intervals. An 80% confidence interval is shown by the hatched lines or the dotted lines, and the solid lines represent the 95% confidence interval. If you did a cross-linking, the confidence intervals were removed because at that time we didn't have noise measurements after cross-linking. So here you can see a patient here who showed progression actually outpaced the 95% confidence interval, both on the normal population and the Keratoconic, you can see here on the posterior surface out past the 80%. But again, if you notice, we did cross-linking, and there's no confidence intervals after the cross-linking was done. You can choose whether you want to have it display just the normal population or the keratoconic. It defaults to showing you both. It's actually advised for you to choose the one most appropriate for your patient. So let's give you an example of what's the value of this. This is a 16-year-old with progressive subclinical disease. If you look down below here, you'll see the bad numbers. The final Ds are fairly low at 2 and 3. If you look at the classification, again, you can see very early disease. If you look at the Kmax, and Kmax is shown over here, I just blew it up over here, this was just under that, quote, 1 diopter progression. I don't know in Australia, in the US, a lot of our insurance companies will not cover unless we show them a change of one diopter Kmax. Here you'll see it's just slightly under. And if you look at the anterior surface, again, this is a 16-year-old with early disease, so we would be using the green gates. You can see that by the second exam, they're well past the 95% confidence interval. If you look at the posterior surface, it's well past the 95 on every parameter. It's way out here. And here again, you can see well past the 95% confidence interval on the thinnest point. Every parameter here showed dramatic progression in spite of the fact that they did not yet reach that magic 1 diopter change. And telling a parent, a 16-year-old, has to come back in a few months to get re-imaged when you already have documented progression is not how we should be treating patients. This is a 15-year-old with very early keratoconus, a 13-month follow-up. If you look here at the Kmax, it actually looks like it got slightly better. Went from 46.1, 45.5, 45.8. So here, a very stable exam on Kmax. And that's because if you look at the anterior surface, it looks very stable. But look what's going on the posterior surface. By the second exam, we're past the 80% confidence interval. By the third exam, we're well past the 95% confidence interval. Documented progression. This is when you want to intervene. You intervene at this point, you're preserving vision. You're not waiting till you have anterior changes, which will be accompanied by visual loss. This is when we intervene. We treat patients. The goal of treating patients is to prevent sequela, not to wait for sequela to develop and then intervene. And it's not just early disease. This is relatively advanced keratoconus. If you look down at the bad display, we're over 7. So this is not really subclinical or early disease. But if you look again at Kmax, it's stable. And again, if you look at the anterior surface, it's not changing, but look what's going on in the back surface. By the third exam, we're here. By the fourth exam, we're past the 80%. And we look at by the fourth exam on corneal thickness, we're past 95%. So it's not just early disease, it's more advanced disease in your older patients where you can have a stable anterior surface and continue to show progression. But the question was, I had mentioned that if you did a cross-linking, those intervals, confidence intervals, were removed because we didn't have noise levels after cross-linking. So how do we define progression after cross-linking? As I said, currently the intervals were removed if you indicated a cross-linking. So we did a post-cross-linking study. The purpose, again, was to measure noise after cross-linking. We originally did this on patients that were fairly shortly after cross-linking, and what we found is that if you're before 12 months, the noise levels were so high from changing that they really weren't reproducible. So we actually went back and did a second study. We looked at patients from 2 institutes, the Elser Institute in Switzerland and the Hamburg Keratoconus Center in Germany, with a minimum of 12 months after cross-linking. We used 2 sites, which is different from our prior work because cross-linking is a surgical procedure with some inherent user variability. We did 3 separate Penacam measurements taken with a minimum of 7.5 millimeters of coverage and an acceptable quality score. And we did pool variance and one-sided confidence intervals. And then we looked at site-specific, which I'll show you later, and time-specific noise levels. We actually looked at not a huge number of patients, 60 patients, 38 from Zurich, 22 from Hamburg. The average age was very comparable between the two, 29.5, 29.9 with a range of 11 to 62, and 28.8, a range of 17 to 56. What was different between the two sites was the length of time from cross-linking. From Zurich, they averaged at 16.6 months and went from a range of 1 year to 28 months. The Hamburg averaged much longer time, 42.6, with a range of 16 months out to nearly 10 years. And we'll tell you why that was important. And again, like everything else, you don't have to know the numbers, but these were the confidence intervals, both at an 80 and 95% confidence interval. And it turns out it's what you think would happen. We have a noise level for a normal population, which is lower, and a noise level, a keratoconic population, which is higher. And when we cross-link, it actually falls between the two. And if you think about it, since cross-linking does have somewhat of a normalization effect on the corneal surface, actually it's exactly what we found, that the noise levels after cross-linking fell between both the normal and the keratoconic population. When we did a geographic comparison, we compared the noise levels between Zurich and Hamburg. They were effectively the same. They had similar ABC values, and they had similar noise measurements. This is a comparison of the two sites. It looks like it's different. That's only because the ends are different between the two, but these are actually almost mirror images. We then just looked at the Hamburg patients because they went from 16 months to nearly 10 years, and we divided them in half. We looked at ones from 1 to 3 years and compared them to those that were from 3 to 10 years. And here the numbers were the same. There were 11 in each group. And again, you can see here almost a mirror image. So once we got past a year, it did appear that the noise measurements were stable out to nearly 10 years, which was comforting because I said earlier we did a short-term study where the noise measurements were very unreliable. So this is the new, or iteration 3 of the ABCD progression display. And if you look at it, you can't really tell much of a difference from the other display. And that's because it will only show the cross-linking gates if you're at least 1 year out. So here, though we have 2 exams after cross-linking, none of them are at least 1 year out. So the blue gates, which you can see down below, that's the blue gates will appear for cross-linking, will only appear if you have data that's at least 1 year out, because prior to that, we don't consider the noise measurements reliable. So this again is a 16-year-old. Here we're selecting again. It's a 16-year-old. We're selecting the green gates preoperatively. And here you can see we did cross-linking. The gates don't appear until we're at least 1 year out. And here you can see the post-cross-linking. And this would show you a very good response to cross-linking. Notice nothing is anywhere near those noise levels for change. This is the same display, and I'm going to back up. The problem is if you show everything, these maps kind of get a little busy to look at. But if you've done a cross-linking, you really no longer really care much about the earlier displays. So here you can actually select out, and here we're only showing the one exam before cross-linking. It's the same patient, and then the exams post-cross-linking. It makes it a little bit easier to read. Here is an example of a good response to cross-linking. Again, this is prior to cross-linking, patient cross-linked, and you can see a consistent good response to cross-linking. And then this is an example of someone who you probably want to at least re-image again as a possible retreatment. You can see on the anterior surface here, that third exam, we're showing change past the 95%. Here on the posterior surface, we're at the 80%. So here, this is someone who you probably want to follow a little bit more closely. I will tell you, normally I would at least do 2 exams that are consistent before. And I would also tell you that I always take, if all I see is a change on the C parameter, I take that with a grain of salt. And the reason for that is when we did our noise measurements, we did them at the same time repeatedly. This patient was just imaged three times. We do know that there is some diurnal variation to corneal thickness measurements. So I do kind of like to see repeated measurements if you're only seeing a change on the C parameter. Most of the time, however, you'll see changes additionally on other parameters. So again, this is that same patient where we're just now showing the exams after cross-linking. It just makes it easier to read the map. And you do that, you can see up here it says select exams. so you can actually select which of the exams you want to see. It just makes the maps easier to read. So what's the conclusion of this? Well, post-cross-linking measurements, variance, or noise can be used after a 12-month period after cross-linking. The noise measurements were consistent over 2 different centers, and they were consistent at a time anywhere from 12 months out to 10 years. And the post-cross-linking gates have been entered into the new, what is version 3 of the Bellin ABCD progression display. Probably the most important slide is this one, and that is, there's been more than these articles already. This is a little bit dated, but there has been independent validation of the ABCD progression display. This is an article that came out in the AJO earlier this year, and in conclusion, it said the ABCD progression identified progression 4 to 7 months earlier than K-Max did. This is an article from Journal of Keratin Refractive Surgery in 21, identified progression average of 6 months earlier than K-Max. And this is an eye in this year. And again, progression display can assess keratoconus progression with high sensitivity and specificity. But on average, we're being able to identify true progression an average 6 months prior than relying on K-Max. And from your young patients, you're not waiting for them to lose vision. And again, at least in the US, there's enough now in the literature that the insurance companies are accepting this as documented progression. The goal, again, always is to intervene and prevent damage, not wait until damage occurs and then kind of halting it at that time. I want to thank you very much. I always enjoy coming to Australia. Thank you. No.
I think we still have 5 minutes left. Does anybody have any questions? We've got 2 microphones around, and just while we, if there's anything you'd particularly like to direct, do you mind, gentlemen, joining the stage? You can stay here with me. Just one thing is, I'd also like to just say that we have Richard White here from Oculus Asia, and I'd like to thank him as well for putting on this, supporting us with this breakfast this morning. Now, if you have any questions at all, because I know there's a lot of information that's been shared, please come have a look, talk to us. If there are reports that you don't currently have and you'd like to see them in more detail, you can also go through it throughout the conference with Richard as well. So, does anyone have any questions?
Michael, my main interest is in detecting early keratoconus before refractive surgery. And we use the Bellin parameters that have the highest area under the curve and are the most discriminating. And one of those that's the most discriminating, it seems to me, from reading, is the average progression index, about 1.08 cutoff or something like that. But it's been my observation that this important number in small white to white eyes seems to be abnormally high, up to 1.24, which is like keratoconus. But I've been forgiving them that because I believe that the small white to white creates that change in the progression index. Am I acting dangerously?
Well, those are 2 different questions. Are you acting dangerously? From I know you, yeah. That has nothing to do with your question, okay? We know each other from, I don't know, at least a decade, if not longer. You are 100% correct, and actually that's work that's currently being evaluated. And it's really a very simple idea if you think about it. If you start here, and the pachymetric progression starts at the periphery, at the thickest point, and goes to the thinnest point. So if you start here and go to here, and let's say you go from 700 to 500, the average change is going to be a more rapid change if the cornea is smaller. And that's true for Asian eyes. And that's something we are actively working on. Actually, I'm not personally, but I actually brought it up to Oculus and Renato. So we are doing a database basically in a Chinese population who tend to have smaller diameter eyes. So you are correct. The database is based on a North American, South American population. But we are trying to actually generate geographic specific databases. And the first one, strictly because of population, is so great, is China. And that should be out shortly. But you are correct. Small eyes will have higher pachymetric progression just by definition.
Michael, Laurie Sullivan over here. Do you think that delay you see in detection from Kmax is simply because the epithelium's remodelling and masking the change, or do you think it's delayed anterior stromal changes?
So there was an article, and I hate epithelial thickness maps, so I'll just tell you right off the bat. We published an article, I was only a co-author, and I can't cite the journal, where we actually looked at epithelial thickness maps where they locate the cones, and of the different parameters, it was the worst. So I'm not a big believer in it, but you may be correct, or it may not be, but it's somewhat moot because whether it masks it or not, it's not showing up. There's a study that was done by Charles McGee, which I'm sure you all know, and actually it's something I had suggested to him years ago, that we look at the anterior surface after epithelial removal. So when you're doing epi-off cross-linking, why don't we image it? And it turns out that when you take the epithelium off and you have obviously cones, the posterior surface was still way more diagnostic than the epithelial removed anterior surface. So there may be some masking, but it's of order of magnitudes less than the diagnostic value of the posterior surface.
Anyone else? We are perfectly to time. So thank you so much, gentlemen. That's absolutely wonderful. And thank you for joining us.